Works. All right, let's get on with the second half. So Kyle, where's Kyle? Is he here? Or did he leave? That was a very inspirational talk. Your journey was obviously something that you spoke from the heart. And I think the slide on what we need to do to improve is all valid points. And I think the part of this process is that shunts will always be around no matter what we do in terms of having medical therapy too. So we need to do both of them right. So, well, it's a pleasure for me to introduce the next speaker, Jignesh Tailor. He's an assistant professor of neurological surgery. He joined our department in 2021, and he'll soon develop, I believe, an independent laboratory focusing on neural stem cells and the origin of childhood brain tumors. He completed his fellowship training in pediatric neurosurgery at Johns Hopkins. Actually, Dodie Robinson's husband or partner is his mentor. And he completed this training in 2021 and he received his medical degree from University of Oxford. And he holds a PhD in stem cell biology from the University of Cambridge. And then during his neurosurgery training in London, he received the highly competitive Wellcome Trust Postdoctoral Research Award that allowed him to complete a neurosurgery training at the University of Toronto, doing an unfolded postdoctoral research fellowship at Hospital for Sick Children in Toronto. And that was with Peter Dirks, who's a world leader in brain cancer research. With regard to his work on hydrocephalus, he's the site PI for our hydrocephalus research network, and he's developing a non-invasive monitor for infants at risk for developing symptomatic hydrocephalus with collaborators at Purdue. And he's looking at AI and machine learning algorithms to predict whether to shunt somebody after IVH or prematurity. So Jignesh, thank you.
Great. Well, thanks so much. Oh, is this better? How about there? That's better. Okay, awesome. Well, thanks so much, Dr. Shah, and thank you for inviting me here to give this talk. I get really excited when I'm in an area where there's so many different disciplines, because I really believe that that's when innovation occurs. It's when you have the intersection of all these different disciplines and different perspectives coming together. So this is really, really fantastic. Thanks for having me here. I'm going to give you a perspective of pediatric neurosurgery, because that's what I do. Slight disclaimer, I'm not a hydrocephalus researcher yet, of course. As Dr. Blasio said, anything can happen and careers can take a turn. So I invite, any ideas for collaboration. And obviously my background is in stem cell biology, and I have an interest in harvesting neural stem cells from brain that we can access as neurosurgeons, and some of these can be important cellular models for different types of diseases. So obviously, as a pediatric neurosurgeon, we're at the forefront of managing hydrocephalus. These scans are not unfamiliar to us, and we've heard, obviously a remarkable story from Kyle, and thank you for sharing that with us today. This is a 3-year-old that I had the honor of looking after this week. And the first scan here is a CT scan that shows the brain. And these areas here are the ventricles, which you can see are blown up. They're very, very large. And we can tell that there's pressure there as a result of hydrocephalus, because there's transependymal edema as well. And here you can see in the posterior fossa a mass, which essentially is obstructing the flow of fluid. So hydrocephalus is a problem of fluid dynamics. You have raised pressure, you raise volume, and as a result, abnormal brain function. That's probably a very simplistic neurosurgeon's view, because obviously there's a lot more to it, and you can have hydrocephalus with normal pressure as well, as we all know. But essentially, it's a problem of fluid dynamics. And here, unfortunately, this MRI shows a brain tumor, which is obstructing the flow of fluid. And as an emergency in the middle of the night, we had to place a drain called an external ventricular drain in order to help the poor kid survive. And so once we do that, we can kind of relax a little bit because the pressure's controlled. And then the next step would be to tackle the cause of the hydrocephalus, which of course in this case is the brain tumor. And he had a resection on Wednesday and is doing really well today. Here's a overview of our operative volume for hydrocephalus at Riley Hospital for Children. On average, as you can see, we're doing about 200 operations for hydrocephalus per year. And that's, both shunts as well as drains and endoscopic third ventriculostomies. And as I mentioned, hydrocephalus can occur due to a number of different etiologies. And tumor is just one of them, but of course, there's so many others, that causes hydrocephalus in many different ways. And as Kyle mentioned, we tend to classify them as those that cause obstruction to the flow of fluid and those that don't have a clear obstruction. And there might be some other mechanisms involved where we don't understand. For example, there's a lot of studies now that show abnormal cilia function in the ependymal cells after post-hemorrhagic hydrocephalus, something we hadn't really thought about. And so again, cellular models are really important in those situations. But yeah, there's so many different etiologies. In terms of demographics, there's a number of different ages, and most of them, of course, are young. They're neonates or infants, but we also do operations in teenagers, of course. So, as Kyle said, this is a lifelong disease. It's something that unfortunately we have to continue to operate on and reoperate on and address as the child grows up. Here's an overview of the types of surgeries that we do at Riley Children's, and this is most of them are shunt surgeries, either initial shunt operations or revisions. And here's a schematic diagram of a shunt, and you can see a tube going into the ventricles of the brain, and that gets connected to a valve, which is connected to a tube, which is tunneled all the way down into the belly. And so the idea is that the valve controls the pressure inside the head, and when the pressure rises as a result of abnormal absorption or obstruction, the excess fluid can come out and be drained down into the belly and be absorbed there. So the other place that we usually place shunts is in the heart. In the atrium here, the pressure inside the atrium is typically low, and so we can that's another site where we typically will put shunts if the abdomen is not accessible to us. But as we've seen, there are problems with shunting, and the biggest problem is the risk of early failure, and that's not small. It's 50% in 2 years. This is a study, probably one of the largest studies that came out of. Oh, can you hear me now? So this is one of the studies that came out of Denmark, and it's a 40-year experience of shunts, and showing the failure rate, which is approximately 50% in 2 years. But that's not the only problem, as you've heard. Infection occurs in about 3%. As children get older, that hardware can break. It can disconnect because the child is growing, and the catheter gets stuck at certain points where there's scar tissue, and so that just tugs on the catheter, and it's not uncommon for us to see it snap or disconnect at the connection points. And then, of course, over drainage. A shunt is not a physiological system, although we try to make it as physiological as possible. And so there's always a risk of us draining more fluid off than we really need to. Or the child can grow out of the problem, and yet, you still have this drainage when they're exerting themselves or whatnot. And so that can cause over drainage. And then, of course, there is some sort of stigma attached to it. Now, I always tell my families and kids that a shunt is not a marker of anything. You can do anything you want with a shunt. You can live a normal life. You can play sports. You can play football. It's, of course, there are risks of breaking a shunt, but then there are also risks of breaking your bones when you do stuff. So I don't know if a shunt, strictly speaking, needs to stop kids from being kids. So the alternative is a procedure which we touched on before. It's called an endoscopic third ventriculostomy. And this procedure, has caused a lot of excitement in the field because, as pediatric neurosurgeons, we don't like, dealing with shunts, right? And this is quite a nice operation because it gives us very good anatomical views, and it can also be very effective. So if, for example, there's a obstruction to the flow of fluid, say at the cerebral aqueduct, say for aqueduct stenosis, well, the idea behind this treatment is that, well, we don't need to worry about that. We just bypass the obstruction. So we will make a hole or a fenestration here at the floor of the third ventricle, so that when fluid falls down into the third ventricle, instead of going into the cerebral aqueduct, it just goes down this new hole that we created, and then circulates around the brainstem and then to the arachnoid villi. And so that is the principle behind endoscopic third ventriculostomy. And there's also been a lot of research now that's been occurring by Dr. Kulkarni and John Kessel and others in the HCRN about this the other half of the procedure, which is called a choroid plexus cauterization. And essentially what the idea behind that is that if we also at the same time coagulate the choroid plexus within the ventricle, then we might be able to, decrease the amount of CSF production and therefore help with the hydrocephalus in that way as well. But there are factors that affect ETV success. And one of the biggest problems with the procedure is that it usually doesn't work very well in neonates and kids less than 1 year of age. As you can see, this is a really nice predictive model that came out of Sick Kids, Dr. Kulkarni here and Dr. Drake and his team put this together in 2009. And it shows that, the success of an ETV can be calculated by the age, the etiology, and the previous shunt. And for each of these things, you assign a score, and the total score that you get is equal to the percentage success that you get. So the older you are, the greater the chances of success. And the etiology matters too. So if there's obstruction to the flow of fluid, then it's more likely to be a success. But for the other etiologies like intraventricular hemorrhage or infection, where there's a lot of scarring, a lot of scar tissue, it may not be as effective. So there are problems with ETV CPC as well. And there are also anatomical limitations. We can't always get inside the ventricle. If, for example, the pressures are high, but the ventricle is actually pretty small, then it's a very challenging operation to do. There's a learning curve associated with doing this because it's an endoscopic procedure, and choroid plexus cauterization as well is tricky and often requires the use of flexible endoscopes, which not everyone is trained to do. And the other thing that people have noticed or questioned really is, what about the cognitive outcomes? Because the one thing that we've noticed is that after endoscopic third ventriculostomy, the ventricles don't tend to go down as much, so they tend to stay big. But the pressures seem to be controlled, and the brain function seems to be, better. So what's not clear is whether that ventriculomegaly or persistent ventriculomegaly is relevant or not. And so people are looking at whether it's better for cognitive outcome. That leads me nicely to the ESTI trial, actually, which is a big multi-center randomized controlled trial that is spearheaded by the HCRN, which is the Hydrocephalus Research Network. And it's really looking at ETV CPC versus a shunt in children less than 2 years of age. And their primary outcome measure is neurocognitive testing. And so currently this is, a trial that is open to the HCRN member institutions only, although there is a strict criteria for, joining this in terms of, how well trained the surgeon is and the volumes that we're doing. And recently, Dr. Kessel reached out to us to say that they were struggling on recruiting patients in this trial and wondered if we could participate. And so once, I hit 10 ETV CPCs, we'll be able to hopefully join that trial, which is exciting. So just a quick word about the HCRN. Obviously, I am assigned lead for this, and that's because we're not part of the HCRN membership, but we are part of the implementation arm. So they have an implementation arm, which is called the HCRNQ. And that was really put together in 2020, around that time, when they wanted to essentially have other centers that could help provide data. And also they wanted to then provide suggestions that, based on protocols that they were using within the HCRN. So we joined the implementation arm in 2020. We were the 5th site to join. And we contribute approximately, nearly 10% of that patient volume. So we do have a considerable volume. We obviously have a history with the HCRN. Tom Lewison in 2006, when he was here at Riley, was one of the first to actually set up the HCRN with John Kessel, and then obviously took the membership to test his children. So it is a membership for the institution and not not for the surgeons per se. Okay, so but I think this is a great platform for us to, let's say, collaborate and also to be part of, because we are interested in doing some clinical studies here, of course, and anything that requires a lot of patient recruitment is always best done with multi-center trials. And this is one example of a study that we're starting at Riley. This actually began as a senior design project by the undergrad engineers at Purdue, and I got in touch with one of the guys who runs that program and said, hey, we have an idea here, because assessing hydrocephalus in babies and neonates can be pretty challenging, and it's difficult to know sometimes whether they're truly under pressure or not, because they have a soft spot here, but it's very subjective. Like, you kind of feel their head and see whether it's under pressure. We also look for suture splay and the expansion of their heads, but there isn't really any objective way to measure. And so I mean, this has been looked at before by many different groups, but when I talked about this problem, they mentioned that there was actually a group in Purdue that had come up with a sensor for the eye. It was like to measure intraocular pressure, and they wondered whether that might work if you placed it on the fontanelle. And so we trialed it with a senior design team. And one of our residents, Andy Witten, who was actually a Purdue grad, he was interested in taking this forward. So now we're at a stage of trialing this in babies. We just got our IRB approved for it, and hopefully we'll get some interesting readouts. But more to come on this. But as a sort of stem cell biologist, I guess one of the questions that I've always asked and wondered is, well, why do ETV CPCs fail in young neonates? And, what is it about their ventricular system that is different or not different? I mean, we have no idea, really. There have been some theories as to why they fail. Some people argue, well, their absorption system is just immature. So even if you make a hole and allow fluid to circulate, they don't have a way to absorb the fluid. through the arachnoid villi, and so the ETV is never going to really work. And that's true in some cases where you have someone who comes back with ETV failure, and you see that the hole that you've made is still there, it's open, but they've failed. And so that suggests, of course, that there are other things at play. It wasn't just the obstruction. But that's not always the case. More often than not, you actually see that hole close up, and you don't see the flow that you can detect on an MRI scan. And I've always wondered why that occurs in young children. Is it due to scarring? Is it just scarring? And sometimes it kind of looks like scarring when you go back into the ventricle and look at it. Or are there other things at play, right? We know that the ventricle is lined by neuroprogenitors. I mean, that's a germinal zone. There's a subventricular zone that has neural stem cell populations, which obviously do diminish with age, and in adults are not really active, and we don't really understand what the function is. But in the neonates, they may have a function. They may have a healing function. And they may be recruited to these areas of injury through pathotropism and other ways to cause that hole to close up. And so it might be interesting to study this. And so one way that we could try to understand a bit more about the human ventricular system and the cells that are lining both the lateral ventricle as well as the third ventricle is to collect tissue and to look at that through histology, through sequencing and spatial transcriptomics, to try to understand, well, what are these cells that are there in early stages but not later. And so this is an IRB that we just got approved to try to collect tissue from the ventricular wall during intraventricular neurosurgery. So for example, sometimes when we have to operate within the ventricle, we use tools such as the brain path or other tubular retractors to get us there. Now, as we're going through, there's always the wall of the tissue that comes off. I mean, in fact, a lot of times we have to just, actually go through it with a sucker, and that tissue is just, goes up in the sucker. Well, actually, this instrument, the Myriad, is a really neat aspirating device that also helps us collect tissue. So you can aspirate the tissue that you don't need or you need to get rid of in order to get access to where you want, but at the same time collect it and harvest it for research. And so this was an idea. I'm putting together a small seed funding grant, which NICO Myriads have, to try to get us started to see what type of tissues can we see if we collect tissue in that way. And part of that will also have ependymal cells. And so if there's an opportunity here for people interested in ependyma to collaborate. So I'll stop there, but I really do want to thank Bonnie and everyone here for inviting me today. That was a pediatric neurosurgery perspective. There's a lot more research going on the adult side, as Dr. Shah mentioned, which I haven't had the time to discuss. This is our pediatric neurosurgery group led by Dr. Ackerman. There's Dr. Kezer, Dr. Wilson, and myself. And of course, I want to thank Mitesh and Mariah Sherrill, who's our research coordinator, who's kindly helped give a lot of the data here. So thank you.
Thanks, Jignesh. Our next speaker is Dr. Stephen Schiff.